Dear colleagues, good afternoon. And if you
The other countries, maybe you need in English. English, okay. Okay, I will continue in English. I already gave the presentation. Maybe the Russian translation would be on a high level. My name is Mынжылкы Бердиходжаев. I'm presenting Central Clinical Hospital in Almaty. In Almaty, we call it Savminka Hospital. I want to share our experience with Flex high radial force stent in combination with Neurospeed balloon in endovascular neurosurgery. In Russian Federation, the stent's name could be Credo. This is my disclosures. This is information about Aclinoflex. It's a laser cut stent and up to 5.5 millimeter. It could be delivered through the 17 microcatheter. It's a catheter for the coiling, and for the stent 6.5 millimeter. It's need 21 microcatheter, and for the 8 millimeter Aclinoflex, you will need 27 microcatheter. And the 3, 4, and 5, 8 millimeter diameters coming in higher radial force. It's a stent specially designed for the stenosis. And concerning the Neurospeed balloon, the balloon is available in lengths of 8 millimeter. All balloons is 8 millimeter in length, and the diameter from 1.5 millimeter till the 4 millimeter. And inner lumen is 17. And Credo stent is like a Aclinoflex high radial force, but it's available in size 3, 4, and 5 millimeter. And Credo heel is the stent covered with the antithrombotic coverage. It's available only in Credo version. Our experience, we used Aclinoflex high radial force stent system for stenosis, and in some cases we used it for the aneurysm stent assistance. But usually when the coil mass inside the aneurysm is unstable, in most of the cases we just place the coiling catheter along the aneurysm neck and just place the stent. Usually it's the balloon assisted cases. We deploy the stent and then we deflate the balloon, and stent is coming to the regular shape, and then we took out the balloon. It allows us to keep the coils inside the aneurysm, and it prevents the movement of the coils. It's a very nice technique, and usually we used it with the Neuroform Atlas stent. With the braided stents, it's not possible because the elongating when you inflated the balloon. But with the laser cut stents, it keep the length at the same position. With the laser cut stent, it's possible. In 8 cases, we used with aneurysm, and in every year, 69 stents were used for the intracranial stenosis. In total, 55 patients. Aneurysm location: paraclinoid, supraclinoid, distal aneurysms, and bifurcation of MC and basilar bifurcation. And the case example, this is a MC aneurysm treated last week. we tried to do balloon assist coiling. It's a wide neck aneurysm, 3 millimeter. But at the end of the procedure, the coil must start to move, and we decide to place a clinoflex stent. Because of the angulation of the branch, the braided stent could change the anatomy, and the second branch could be thrombosed. That's why we take the laser cut stent, and in this case, we took the scissors and we cut the distal tip of the delivery wire, because it could be source of vessel rupture or by the puncture of the delivery wire. And finally, you can see the vessel anatomy is dramatically changed. We used 4x20 Aclinoflex high radial force. And the other case, we used combination of Neurospeed balloon with the Neuroform Atlas stent. It's a wide neck MC bifurcation aneurysm with the M1 segment stenosis. First, we did angioplasty with 1.5 by 8 millimeter Neurospeed balloon, and through this balloon we placed Neuroform Atlas stent, and the diameter of the Neuroform Atlas was 4.5 millimeter and in 21 millimeter in length, and it's allowed to create the neck of the aneurysm. And then we placed coils through the Neurospeed balloon and completely embolized the aneurysm, and also we treated the intracranial stenosis in M1 segment. This is final images. So about stenosis, when we talk about stenosis, the biggest trial and the trial changed our practice is a Sampris trial. And in Sampris trials, medical management group, they had a 5.8% of complication in 30 days of follow-up, and in balloon angioplasty and stenting group, they had 14.7% of complication. That's why after Sampris trial, the recommendation was the medical treatment in this complex patient group. And it was the delay of the treatment for this complex group of the patients. And our best numbers should be 5.8 or lower complications comparing with the Sampris. And in Sampris trial, the most of the complications was during the exchange maneuver, because the angioplasty done by the balloon from the Boston company, and then with the 300 meter long wire, they should exchange the balloon for the wingspan stent, and it's not so easy to deliver the wingspan stent, and most of the complication was during this process. They punctured the distal vessels and created intracerebral hemorrhage and hematoma, and it was the most of the complication part. In our group, we treated 195 patients. Most of them was males. Median age is 61. It's mostly 45 till 74 years old. It's quite active patients. And most of the part of stenosis located in ICA. It's the vessel has less perforated arteries, and in Sampris trials, most of the ischemic complication was concerning the perforator occlusion. And on this table, you can see the perforator segment is a M1 segment and basilar segment. And the rest of the stenosis you can treat without any risk of ischemic complication. That's why I think it's not so correct to put all stenosis in one box and do analysis and say the angioplasty and stenting is a risky kind of treatment. 99% of our patients had hypertension, half of them had diabetes, 1/3 had coronary disease, and 25% had myocardial infarction, and they had bypass or stenting on coronary arteries. 65%, 66% has ischemic stroke, 1% has hemorrhagic stroke, and 12.5% has a transitory ischemic attack. Complication of the treatment is 569%, intraoperative 363%, and postoperative 2%. And MRS6 we had in 2 patients is 1%. It's less than complication rate in some trial. Medication in angioplasty group, we gave aspirin. In stenting cases, at the early experience, we gave clopidogrel, and more late experience with the mono antiplatelet therapy with ticagrelor is nearly half of the treated patients. The stent types we used mostly balloon expandable coronary stents, and last 3 years we started used Aclinoflex stents, and amount of Aclinoflex is 23.6%. And location of the stenosis. And for the balloons, we used Neurospeed for the later experience, and for the early experience we used Camus balloon from Asahi and other coronary balloons. And wires in all stenting cases in intracranial stenosis, we use coronary wires, and most of them Xeon Blue from Asahi. It gives stability, and usually these balloon catheters bit stiffer, and regular narrow wires could be less stable to deliver these balloons. And case examples. This is patient with the basilar artery and right vertebral artery stenosis. Patient was previously treated in September 2021 in other hospital. Our colleagues placed coronary stent in V4 left vertebral artery, but the basilar stenosis still there. They recommended medical treatment, clopidogrel, aspirin, and statins, but clinical symptoms didn't decrease, and patient asked to treat him. We did angioplasty with 2 millimeter Neurospeed balloon, but we inflated it up to 14 atmosphere, and in 14 atmosphere the diameter of the balloon is 2.5 millimeter. Then we placed Aclinoflex stent 425 and covered all stenosis in basilar. And then we did angioplasty with the same balloon in V4 segment and placed another 4x20 stent in right vertebral artery with good result without complications, and patient decreased the ataxia and the other cerebellar symptoms. This patient with the vertebral artery stenosis with occlusion of the contralateral vertebral artery, we did the same balloon angioplasty and the placement of the Aclinoflex stent, and we had some complications. Intraoperative thrombosis in 5% of cases, and 2.6% of cases postoperative, and stents were removed. and one complication ended with the MRS6. This patient had A1 occlusion and critical stenosis of the supraclinoid segment. At this time, we had aclinoflex only in 15 millimeter lengths, and we discussed with the patient. We recommended him to do bypass, STA-MCA on the right side, but patient said, I want to be treated by endovascular methods, and we did angioplasty with the coronary balloon. It was 2.5 by 20 millimeter Camus balloon, and then we placed through the headway 17 two intracranial stents, aclinoflex 4 by 20. It's a final result, and we discharged the patient on day 5, and the next day after discharge, patient was hospitalized in emergency hospital, and the patient had the left side hemiparesis and decrease of consciousness. Our colleagues called and said, your patient is coming by the ambulance, and we asked to do CT. CT was normal, and we took this patient to our hospital, and we did angiography. You can see the acute stent thrombosis, and we tried to do thrombectomy and aspiration, but after 15 minutes, stent reoccluded, and we decided to do stentectomy. We placed the solitaire 630, and we did stentectomy, and then we waited for 15 minutes, and artery start to occlude, and we decided to place solitaire as a stent, and then we took this patient for the bypass because we had one time of complication. We thought that maybe the second time it could be the second complication of thrombosis of the stent, and we placed the bypass. And this angiography done after bypass, you can see the bypass is patent, and also the solitaire is patent too. And now patient secured, and after 8 days, we discharged the patient on the preoperative neurological status. This is quite interesting material, and it allows us to do treatment in complex patient and with the low number of complications. And if you have questions, I would be very thankful, and thank you for your attention. If you have any question, there is my email and the contact numbers. Thank you.